Hello, I'm Helen Zorbas. It's my pleasure to welcome you to the first of two programs on gynaecological cancer produced by Cancer Australia and the Rural Health Education Foundation. We're delighted to have health professionals from rural and remote areas of Australia joining us. This program focuses on the psychosexual support needs of women who've been affected by a gynaecological cancer. In Australia each year, about 4,000 women are diagnosed with a gynaecological cancer, about 1/3 of whom live outside a metropolitan area. So as well as facing the impact of a life-threatening diagnosis and its treatment, for these women there are often unmet needs associated with isolation and limited access to supportive care. As rural health professionals, you have a vital role to play in providing information and education that can assist women through their cancer journey and survivorship. We hope that through this broadcast you gain a greater understanding of the psychosexual issues facing women who've been treated for a gynaecological cancer and of the evidence-based information and resources that can assist you in supporting them.
Hello, I'm Norma Swan. Thanks to Helen Zorbas for that introduction to this programme on gynaecological cancers and psychosexual care. It's an initiative of the National Centre for Gynaecological Cancers, which is part of Cancer Australia and funded by the Australian Government. There's a big need, as Helen said, to address the psychosexual health needs of women affected by gynaecological cancers. And by those we mean endometrial, uterine, ovarian, cervical and vulval cancers. So the National Centre for Gynaecological Cancers has developed 6 online modules to assist health professionals develop the knowledge and skills to support women and partners experiencing psychosexual problems following gynaecological cancer. Tonight we have 3 members of the team who helped develop the modules, as well as an experienced general practitioner from Tamworth. We're also going to preview some of the case studies in the modules. You'll find the links to those modules and other useful resources on the Rural Health Education Foundation's website, rhef.com.au. Let's meet our panel. Carmen Ast is a general practitioner from Tamworth in New South Wales. She's been in general practice for many years and has a particular interest in women's health. Welcome, Carmen.
Thank you, Norman.
Mark Davey is the Acting Clinical Director of Surgical and Specialties Service at the Royal Adelaide Hospital. Mark has an Order of Australia for service to women's health and is a leading gynaecological oncologist. Welcome, Mark.
Thank you.
Kendra Sundquist is Manager of Supportive Care Development at Cancer Council New South Wales. Kendra's also been involved in the development of cancer and sexuality teaching packages for clinicians. Welcome, Kendra.
Thank you, Norman.
And last but not least is Patsy Yates, who's Professor of Nursing at QUT, Queensland University of Technology, and is also Director of Queensland Health's Centre for Palliative Care Research and Education. And in fact, Patsy was the project lead for this National Centre for Gynaecological Cancers project. Welcome to you all.
Thank you.
Welcome, Patsy. So what are we talking about here between sexual health, sexual dysfunction, Kendra?
Well, if we're talking about sexuality, I just want to say that, first of all, sexuality is not just about sex. It's a bit of a multifactorial construct which includes physical, the psychological and social dimensions, and that is heavily influenced by our culture, our family, our religious beliefs, legal issues and a whole lot of other definitions.
What is it? I mean, gynecological cancer is a huge issue and the treatment can be quite mutilating, so presumably there's a plethora of effects.
That's right, Norman. We can have anatomical changes directed at the treatment for the disease, and these may include a dry vagina. Unfortunately, many women become menopausal because of our surgery or because of other treatments which we offer them. So there can be anatomic changes, there can be hormonal changes which can affect other sexual functions. Less commonly, but especially in patients who have radiotherapy, there can be altered function for bowel and bladder, and this can cause embarrassment and insecurity for our women.
And presumably sometimes it's not as bad as anticipated.
Oh no, it varies widely, of course, but in counselling a patient you always have to give them the whole gamut so that if they experience something they know it's not something dramatic that's happening just to them, but it's something which can be anticipated.
So what are the commonest ways that, if you were to ask women, Patsy, what was bothering, what are the sorts of things that they say And does it differ much between cancers?
Yeah, it will differ between cancers and between cancer treatments, because it's often the effects of the treatments that we're really seeing. So the sorts of things that women might describe might be things which are very simple in some ways, and that they might sort of describe that they're feeling tired and have a lack of desire. Even though that seems simple, and you know, that can be quite distressing for the woman and her partner. But I suppose there can be other effects which women might describe which are more complex and more difficult to manage, and they can be things such as pain when having sex. They can be things such as altered sensation, altered arousal, and some of the simple practical functional limitations that there might be associated with things like lymphedema, which may restrict women and the sort of positions that they may be able to be in. And so a range of different things may be described depending upon what sort of treatment and what sort of cancer that they've had.
Carmen, I suppose, with prostate cancer in men, one of the strongest predictors of how well they're going to sexually function after surgery is their sexual function before surgery. Presumably the same thing applies to women going through the experience of gynecological cancer.
Yes, well, I think it does. It's an expectation that the woman might have about going back to what the function was before the operation, or maybe it would open a whole new window of ideas to her when people actually start talking about sex for the first time with her, which is quite likely in this scenario. It might not be something she's ever spoken about.
So in other words, there's a therapeutic opportunity, Kendra?
Yes, well, it could be a therapeutic opportunity, and I think what was interesting, there was some research done in Australia some years ago, 2003 I think it was, that indicated that there was 70% of women that experience sexual difficulties. So obviously therapeutic opportunities are important for women generally, but also particularly if they're experiencing gynecological cancer.
Mark, how do you deal with that situation where, and I suppose it's when to ask and when to anticipate an issue, deal with the questions to ask, because obviously the results you're going to get afterwards are coloured by somebody's experience before. If they're in an unhappy, unsatisfying sexual relationship, or their libido was already low and they weren't looking for sex, all sorts of complications can occur afterwards which you weren't ready for as a consultant, as a clinician.
Most definitely. I think certainly my approach is when I meet a patient, a woman for the first time and she becomes a patient, she obviously is very nervous about the disease, about the treatment and about the outcomes. And one of the things that I tend to say is, I don't quite know where your sexual situation is at this stage, but one of the things that I'm planning to do is to fix you from your disease, and part of the fixing and rehabilitation is getting you back to normal function. We may not talk about sex now, but it's on my agenda and we'll bring it up at a later stage. So I've paved the way for them to think about it.
Carmen, what's been your experience as a GP? What are the key issues here from your point of view? Because it's clear from the research that people like Kendra, Patsy and others have done is that people don't ask.
Yes.
And women don't tell if they're not asked.
Exactly, and I think different GPs have different comfort zones in this area. It might be something you've broached before with the patient in the context of a pap smear. You might come across somebody who does have a history of sexual abuse that they might disclose at that time, or in a difficult relationship. So you might actually know a little bit about their background and where they're coming from, but then again you might not be privy to any of that information, and it's difficult to start talking about that in the different contexts.
And of course, as a clinician, if you're having sexual problems yourself, this becomes a complicated problem.
On that conversation and your comfort zone. And if you look uncomfortable, then the patient's going to be even more uncomfortable.
What myths are out there about this whole area, Kendra? Well, let's start with the women themselves.
The women, in terms of their cancer or in terms of sex? In terms
both.
of their cancer?
Well, it's plenty of myths about sex.
Okay, well...
Men tend to live in that world a bit more than women, I think.
Okay, all right, well, let's just... the cancer often it can be seen as a punishment for misbehaviour, sexual misbehaviour. There are also myths from the partner's side about the risk of catching cancer. I think one of the other things that often women are concerned about before they get cancer is perhaps their genitals. There's a lot of emphasis now on the size and shape of women's genitals, much more than I've ever seen before in terms of the media. And people are even having reconstruction done on their labia to look normal, whatever normal is. So I think women generally can be very anxious about their genitals and also about their sexual activity. What's normal? How often should I be having sex? So there are a lot of concerns that women have.
And men, as you say, have their own
and men
myths
have their
about
own and myths, yes. They also, men might be concerned that they could catch cancer from a woman who's had cancer.
And some are worried about the radiotherapy, that they're going to get radiation.
Catching it, yes, or chemotherapy, radiotherapy affecting them, yes, if they have sex.
What myths abound amongst health professionals, amongst clinicians?
There's a lot of myths about and assumptions made about people that do or do not have sex, like old people, asexual. They don't think that old people enjoy sex. I've been at a workshop where a woman said she had her first orgasm at 72. And that
Good luck to her.
That's what I said.
Shame it took that long.
It blew everybody away, I can tell you, in the audience.
Probably blew her away too, but no, we'll go there.
It did. Yes, so I've lost my plot now.
So the myth about older people not having sex.
Oh yes, older people, and also I think there's myths about what's good sex. There's only one way to have sex. There's a lot of myths about things that you should and shouldn't do that are harmful, that can spread disease. There's a whole lot of myths. There's a lot of misinformation out there. We think people are really cool about sexuality because they read about it a lot in the paper, or see it on TV, but I actually think people are more confused than ever in a way, because there are so many things that they think everybody else is doing that maybe they should be doing, yet they feel guilty because to them that is not normal.
Patsy, can you do any harm by having sex after gynecological cancer?
Well, obviously, you need to be conscious of healing, and so that, yes, certainly there can be times when one needs to go carefully, but but it depends really, I suppose, upon what the advice of the treating oncologist would be as to whether or not there is. But it's unlikely that once healing has occurred that there will be any damage. Obviously, one of the things when you're sort of educating and giving information to women and their partners, you'd be advising if there's practices or things that they're doing which are uncomfortable or painful, that one would need to be careful about that and perhaps be consulting their doctors. But generally, once healing has occurred, there should not be any difficulty.
How long-term are the psychosocial effects post-gynecological cancer?
Well, I think normally if they're not dealt with and brought out into the open, they can be lasting. And really it's up to the individual doctors and other treating members of the team to bring up the subject of sexuality, bring up the whole subject, and question the patient to see if there is a problem and deal with it appropriately, depending on what the problem is.
Let's go to some practical stories now. And this is one story from the modules about Jane. And Jane's 58 years old. She's postmenopausal. She's repartnered. She has a second husband, been with for 6 years. She had an abdominal hysterectomy, bilingual salpingoophorectomy, and pelvic lymph node dissection for stage 2 endometrial cancer. Because of the stage of her cancer, she required high dose rate brachytherapy to reduce her risk of recurrence. For those of you who don't know what high dose rate brachy is, it's where they put in high dose seeds and for a period of time take them out, and then has repeated treatments. Marg, what are well, first of all, let's start with the general practitioner. Mm-hmm. You've got somebody like this.
Yes.
You're not going to see many cases like this in Tamworth,
no.
or even in the busy metropolitan practice. This is like a once-in-a-lifetime story, isn't it, really?
That's right, yeah.
But you've got to be ready for it.
Oh, exactly. You've really got to get those resources going so that you know how to help this woman, because the side effects of treatment are obviously long-lasting, and she's going to have lots of problems that she wants answers from, and whether you're the best person to do that or somebody else.
So in practical terms, when you have a woman with gynecological cancer in a country town, to what extent are you involved, or does the gynecological cancer team kind of take over?
Well, I think in that initial treatment phase, when people are going down and having, brachytherapy, possible chemotherapy, and obviously the major surgery, that's all done in a major centre far away, and we get letters back occasionally.
If you're lucky.
Yes, and discharge summaries if we're lucky.
Mark's good at sending letters, I'm not sure about the others.
But I think slowly as time goes on and that person is followed up less and less often, simply because of distance and inconvenience to the patient, the general practitioner takes over that role and is left with obviously issues that may not be apparent in the first instance but turn up 6 months, 12 months, 3 years down the track, and we've got to try and cover our bases so that we can deal with those problems at the time.
So just to outline the issues, Mark, medically that are going to affect Jane sexually and psychologically as well, because it's not just the physical side of sex.
I think the first thing is the operation. She'll have a hysterectomy and both her ovaries and tubes will be removed, as well as the lymph glands. As a result of this, she may experience painful scar at the top of the vagina if she's having intercourse, and especially if she's had brachytherapy on top of that, she's likely to have dyspareunia because of lack of lubrication. As time goes on, and if she avoids intercourse because it's uncomfortable, she's likely to experience vaginal stenosis. So this then becomes a worsening circle for her. She may develop lymphedema of her legs, and that again limits her movement and her functioning. And because of the brachytherapy, she may also have problems with urine and bowel function.
So an irritable bladder and an irritable bowel,
Yeah.
which can be quite painful.
And unreliable, so that she loses control, and so she loses confidence.
So practically speaking, Patsy, what do you do for someone like Jane then, holistically?
Okay, holistically, I mean, I think some of the other issues that probably could happen for someone like Jane are not just those physical issues, but she may just have that whole body image and not feel as attractive and not actually feel as though she is interested in having sex, or that her partner will be interested in sexual activity.
Going through all that.
Yeah, so I think one of the first, holistically, one of the important things to recognise is that this will be very individual, and that how people respond to what this means to them needs to be understood. So we need to actually sort of see how significant this is, and at least give an opportunity to understand that.
Well, who has that conversation?
Yeah. Yeah.
And remember, we're talking about people in the country.
Yeah. Well, I think who has that conversation, it actually should happen right at the beginning, at the time that treatment is being planned. So that's sort of, the treatment team's responsibility. I think even before that, if the GP feels comfortable and the woman has questions around, well, what might this treatment mean when I go down to the city to have this treatment, I think that the GP needs to feel comfortable to give information that these may be issues, but then positive information that there are things which can be done and that they will be followed up on. So, and following treatment, I think that who ask these questions, then it really, for women who live in rural communities, it really often will come down to the GP, who really will need to be able to feel comfortable to ask about those issues, to give practical advice, and there are some practical tips that you could give.
So Kendra, she says to you, the woman says, I don't have a partner at the moment, but I'm planning to have partners in the future, and the thought of this vaginal stenosis terrifies me. What can I do?
Well, I'm not a clinician, but I would imagine that she would need to talk to her GP about the use of vaginal dilators, perhaps, or some women prefer to use sex toys. I'm not sure that. I think there's a lot of issues around dilators, and I think I'd probably ask Marg perhaps to come to get me out of this hole.
Coming on here.
I just don't want to say anything that's clinically incorrect.
It's a very controversial topic.
Well, I think we can all be very specific in all of this sort of thing. Anything that can make the woman feel more comfortable about using her vagina. And if a sex toy is the answer, well, then they're much more friendly than dilators. And I usually recommend that they pop along to the nearest sex shop, have a look at the whole range, and make sure you buy some lubricant.
Good lube.
And I mean, these are practical questions. First of all, you don't want to go into one, but you could always do it online. But what about size? Because you could overstretch, presumably, at the beginning if you're talking about a tight vagina already. I mean, how do you deal with that sort of thing? What's the practical advice?
Well, I guess really the practical advice is try something medium.
Right.
And medium can be elastic, obviously, but then also make sure that the woman is very relaxed and comfortable before she tries. And so obviously you're not going to do it in a hurry, and you need quiet, private surroundings in which to experiment.
And I mean, this is important, to ask these questions. And is it daily? Is it once a week? I mean, do we know what the evidence is in terms of stretching and stenosis prevention, what works and what doesn't?
There really is no good evidence because the practice is so widely variable. I know that there are some units who say 5 minutes 3 times a week is sufficient. In my experience, I don't think this is sufficient, and it needs to be daily or for half an hour at a time, a longer period of time, so that there is an opportunity for increased blood flow, because after all it's the blood flow that's going to be important in making sure that the tissues remain elastic.
And forevermore? Or, I mean, at what point can you stop?
Well, when she finds a fella, she's probably all right.
Right. Well, one who's sexually active. And what about the sexual response? I've spoken to researchers in this area who say that women, similarly to women who have sexual problems without gynecological cancer, is they believe they don't sexually respond anymore, and reteaching women that they are women who can be sexually responsive. How do you deal with that as a general practitioner?
Well, I think you know, some of that, and probably most people are sort of are aware of sort of the early research of the Masters and Johnson, where they, you know, described that sexual response cycle, where they talked about, you know, that whole notion of their need, you know, the desire and then the arousal and all those sort of stages. And I think it's useful to think about some of those, that it is a range of sorts of issues which you might want to deal with. So if it's you know, about lack of desire or a loss of libido, then there's things which one can do to perhaps, you know, a nice dinner with a glass of wine with your partner. Those sorts of things might be some very practical things you could do. But if it's actually more really around the arousal that is affected, then again there may be some ways which you can sort of slowly give people advice around how to you know, start to feel sensual again. So it might be spending some time sort of learning how to touch each other again in safe ways, and those are the sorts of things which...
So this is the sort of thing that where, you know, let's not have sex. We're just going to touch and relearn touching and experiencing it, not even on our erogenous zones, and just take it very, very slowly.
That's right.
Just
and that's,
massage, really.
Yes.
That's right, those sorts of things. And as, you know, Kendra sort of talked about, that, you know, sexuality is a very complex, multifaceted sort of concept, and part of that is sensuality, and that is just sort of feeling with the senses and what makes one feel good.
And I've heard of researchers trying to work with female erotica, not pornography, to actually just relearn some response. Have you had any experience of working with patients with that, Carmen?
Not specifically, but I think people, sometimes women do need extra things to get them going, and watching a movie
or remind them.
Yes, that's right. Is sometimes exactly what they do need, or reading a raunchy book, you know, where it describes in good detail. I think that does do it.
Mark?
I think that also we need to remember that many women with gynaecological cancer are still able to have hormone replacement.
In fact, there's a question here from Murtaza Kanbai, who's asking, in Queensland, asking, would, you know, this be a candidate for HRT, and would it make a difference?
It may make a difference. I think there has to be a holistic approach. It's not going to be just giving some hormone replacement is going to make the difference, but added to the other things which the other panellists have been talking about, it may tip the balance in the right favour because of improved hormone tissues.
Lots of questions.
We need advice from you, specifically about each individual case.
Yes, I think that's
whether
right.
that's allowed or not.
Well,
we wouldn't go there otherwise.
No, for ovarian cancer, for ovarian cancer, cervix cancer and vulval cancer, there is no contraindication to hormone replacement. When one needs to be a little bit more careful with endometrial cancer. But usually the woman who has large reserves of peripheral fat doesn't need the hormone replacement.
Yes.
Because the fat's producing estrogen. Question from Sylvia Pomeroy, James Cook University. Any suggestions how to approach the subject of sexuality versus the culture that older people don't have sex, especially with nursing staff or people in institutions? How to raise
how to raise the issue? Well, I think that I was really interested in some of the comments that Marg and Carmen made before. I think one of the first things to do is normalise it. I think, you know, to approach it is by saying that, you know, I've been working in this area for a while, or I've had lots of patients who've had similar situations to you, and I know that this often can be a problem. So I think that's one of the ways, normalise it, and then ask that sort of open question around, you know, is this something you'd like to talk about? And waiting for that right moment that person is ready.
Richard Farrell from Bega Valley Health Service asks, what percentage of patients experience an anxiety or mood disorder following gynecological cancers and their treatment?
In my experience, that's quite a significant long-term issue often. And it may be very much tied with their psychosexual role or with their change in body image.
Question from Kristen Young from the Defence Force Psychology. Thank you for asking the question, Kristen. Concerning vaginal atrophy, is it really a case of use it or lose it? In other words, how likely is stenosis and or atrophy statistically? Mark?
It is relatively common the older the woman is. So the further past the menopause she is before she has her treatment, if she's having intracavitary radiotherapy, the more likely she is to develop it. So I would have thought at least half.
At least half.
Will have some form of stenosis. It won't be unusable, but it will be uncomfortable.
I don't think I finished the story about mood disorders there before. I think I sort of glanced off it. Do we know how the extent to which the mood disorders are related to distorted body image versus sexual problems versus just a reaction to cancer? Do we know, Kendra?
Oh, I don't know. Somebody else might want to comment on that. But we work a lot with people who've survivors of cancer, gynaecological cancers and others. And what we hear is that the impact in terms of their relationship, if they are in a relationship and sexual relationship, is that the expectations that everything will get back to normal, but there isn't a normal. It has to be re-established again, both from the if they have a partner, from the partner's perspective, and from the woman's perspective as well. So there's this sort of renegotiating period as well, perhaps, of and talking to each other, which is terribly important.
Actually, perhaps, Norman, I could bring a little study that we did in South Australia. We took a group of women who had a hysterectomy for a cervix cancer and compared them with a group of women who had a hysterectomy for benign reasons to look at their adjustment and psychosexual rehabilitation. Sure. And the interesting thing was that in terms of their actual sexual function, there didn't seem to be a lot of difference in terms of the physics, the physiology, but in terms of the emotional support, it was quite incredible. There were a group of women who found that they left their husbands or their partners as a result of their cancer. And some of these women would say things like, I saw that couch potato sitting over there and I thought I've had a second chance at life and I'm off. And there were others who said...
So it was a renewal.
And there were other partners who said, I saw what she went through and I thought, we've got a second chance, let's do it together. Oh, so nice. There were several groups and this is the emotional support.
Yes,
and so it seemed, without radiotherapy and chemotherapy, that in the straight surgery side of things, that it was more the relationship which they had before, which was the...
rather than the disease.
We've also done some research with carers, and often the carer positions the patient in a different way as being asexual, and so that can cause problems in terms of renegotiating their relationship.
Yes, exactly.
So psycho-oncology is obviously an important part, and that's where you've got a problem in country towns where you don't have necessarily the psycho-oncology support that you would look for.
That's right. We have we usually have psychology services available to us, but that somebody who specialises in this particular area, whether it be sex therapy or grief loss counselling to do with an oncological problem, it's hard to know.
What about the issue of the person who's experienced sexual abuse? Because this could bring back all sorts of terrible memories. Mara?
That is exactly so. I think we have to be very careful with these people because they are much more fragile, and rehabilitating them can be something which I think is out of my area and needs to go to specialist sex therapy.
And it's one of those things, I think, too, that you don't sort of take for granted, and that's why that beginning of sort of asking permission to sort of talk about these things. And one of the other things that I've learnt over time is that it's also useful to ask the woman first about whether or not she'd like to have the partner involved in the discussion, rather than assuming that this should be something that we'll start having this discussion together.
And Aboriginal women?
I think in my experience, it's actually quite difficult raising sexual issues with Aboriginal women. Not all, but often there's a cultural issue that they just don't want to talk about it. It's a bit of a taboo. And
so do you need to work through other women other Aboriginal women?
I think it does assist if you've actually got Aboriginal health workers or
who are female,
people within
obviously.
the culture.
Because
will
women's
actually
business is
broach that.
important.
Yeah,
Yes.
I think sometimes it's very hard for
And presumably an anticipatory approach where you know it's going to be an issue and
Yes.
engaging with female Aboriginal health workers from the
Yes.
same community.
Yes, it wouldn't be appropriate for a male doctor to start asking those questions.
Norman, I've spent 20 years working in the Northern Territory looking after the outreach programs, and I think that this is one of the greatest problems that the Aboriginal women have. It's secret women's business. It remains so, and it remains so even after they've been cared for, and it is something which I think we have not addressed at all well.
Just a few supplementary questions from Kristen Young, member from the Defence Force. Is stenosis and atrophy reversible once it happens?
Once the fibrosis has become solidified, no.
So get in early.
Early.
And she also asks, is vaginal oestrogen contraindicated if you're BRCA positive?
Not in the slightest.
A comment, I think, from Annie Miller at the Cancer Council New South Wales. She's interested to hear that you mentioned going to the closest sex shop, yet this is a rural broadcast and not everyone has a connection to the internet, nor has a mindset to order something safely over the internet. So presumably it's a complicated situation.
Yes, exactly. It would have to be a locally resourced thing. I guess, I'm not sure. I suppose a GP might find out where the nearest access point would be, or nearest big town, regional centre that would have such a thing.
Maybe a bit of bit of secrecy would be a better idea, and go to somebody else's big town.
Yes.
Yeah, well, that's the
Travel
anonymity of
100k down the
usually
road.
they're quite well covered shops, I find, across the street. Once you get in, nobody knows you're there.
Yeah.
But they do have brown paper parcels.
Yes.
And Sichuan Lee asks, from Queensland, asks if you're actually going down the vaginal dilator route rather than the vibrator or or sex aid route.
Sex toy.
Sex toy route. Where would you get a vaginal dilator from?
Most of the hospitals who are treating the patients would have a series of dilators which they would provide for the patient before she's leaving the hospital. So that should be the oncology nurse in the treating centre.
Possibly a local gynaecologist may have access to similar.
Yeah,
or their nurses.
they'd probably have pessaries and things like that. They'd be unlikely to have a set of dilators unless they become very interested in the whole topic.
But you might as well go the consumer way and the sex toy way, much more friendly. Let's have a look now at Norma's story. Norma's a 78-year-old independent lady who's been widowed for 15 years. She's 4 grown-up children, several grandchildren, who all live locally, and they're very supportive. She's very active in her community church, plays bowls, goes to the Senior Citizens Centre. She's had a wide local excision and bilateral groin node dissection for stage 1 squamous cell cancer of the vulva. And here you see her talking to the social worker about 2 weeks after the surgery.
I've just seen my specialist today. He thinks I'm a bit anxious, and he's worried that I'm not coping as well with things at home as I used to. So he's asked me to have a chat with the social worker.
It's been good to have a chat about how things have been going for you since you went home from hospital, and I'm really pleased to hear you've got such a lot of support from your family. One of the things I did just want to talk about is the impact that this has had on your sexual relationship. What I know from most women is that there's an interruption to their sexual function, even if it's only temporary, and even for women who aren't in a sexual relationship at the moment, they sometimes have some worries about how it might be in the future. So I'm wondering, are those things a concern for you? Are you in a sexual relationship at the moment?
Well, I'm 78 years old, you know, and my husband died 15 years ago.
You know, Norma, one of the things I've learned in this job is never to make any assumptions. I've learned that age isn't a barrier to sexuality, and neither is being single. Lots of the older women that I'm seeing are really quite happy in their sexual relationships. And even for some women who are single, they're worried about how their sexual relationship might be in the future. So is that something that's of concern to you, Norma?
Well, there is Bill, a very nice gentleman I met at church, and we play bowls at the same club. He's a widower, but I don't want my children to know. What would they think?
Norma, whatever we discuss in this room stays in this room. It's completely confidential. Even if we identified some issues that we needed to discuss with other members of the team, I'd do that only with your consent. And of course, I'd never disclose any of this to your kids. Is it something you feel comfortable talking to me about?
Actually, that would be good. I've been a bit worried about it. I haven't even discussed it with Bill, and I'm sure he's wondering about it. After all, it's only been a couple of weeks since the surgery. And I can't ask the doctors about it. Whatever would they think of me?
Well, what would you think of it, Carmen?
Well, I think she'd be amazed that we'd actually be quite accepting of whatever she comes in with, but she's obviously very acutely embarrassed.
Made worse by country town, where you kind of know people.
Yes, exactly, in a small town, and this is a very confidential matter for her. And it's a bit sad that a GP might not even be privy to knowledge about how happy she might be in a new relationship, because we'd be blessing her, really. So, but I think we have to acknowledge that sometimes people won't tell their local GP because of small town issues, confidentiality issues that they feel might be broached, and so sometimes the multidisciplinary team in the major centre might be a better way of getting that counselling across to her.
What's your opening gambit, Mark?
For this lady?
Yeah.
I think we should say, how's your sex life?
And you do that for all ages?
I don't like to judge. I might be wrong.
And so some people might get a bit nervous when they hear you say that. I mean, how often do you get rebuffed on that?
Surprisingly, very little.
And they respond?
I think they're quite... sure, they might be taken a bit back that I raised the subject, but they feel that they can trust me to know that I'm trying to think of all aspects of their care.
So we've got a question here from Queensland, which is, should the partner be included in the discussion?
Not until she says he can. Or she can.
Is there any benefit, known benefit from doing that, or just allow you to be guided by the woman herself?
Yeah.
Betsy?
Yeah, I would always recommend that. I think that, you know, it's hard enough having those discussions as it is, but I think it's obviously much better to have those discussions with the partner, to have them together, but I think you've really got to be given permission and be led by the woman as to what she feels comfortable with, because we don't necessarily know, and part of that might be questioning a little bit about their existing relationships to understand that a bit more, but we don't necessarily know what the nature of that relationship is and whether there's difficulties there which actually may make it worse.
So what are the issues here, Kendra, from a consumer perspective, from the woman herself, if she doesn't feel comfortable talking to her GP about it, but she's desperate to talk to somebody? What are the routes here for women?
Well, she could obviously find out where she could get information. I mean, for example, the Cancer Council helpline, which is a national number, 13 11 20, you know, they're experienced health professionals online to point her in the right direction or send information. So there are ways of actually getting that information and getting some support. It's just a matter of GPs and other people being aware of where to refer people, or giving information to the woman.
And male GPs flicking it to the female partner.
Yes, or the practice nurse, I think, sometimes can have that conversation quite comfortably with patients. Yeah. They might even be doing the pap smears in some practices.
Doing it already, and there's a great advantage to doing that. Let's now go back to Norma. She's now talking to the clinical nurse consultant, Carol, and discussing some of the physical effects of her treatment.
I had a couple of conversations with Kate, the social worker, about how I've been since the surgery. I've also wanted to talk to Bill about our relationship, but I don't know how to start the conversation. I really didn't think it would be as bad as this, as I'm not feeling my usual self. Kate suggests that I have a talk with a specialist nurse, Carol, who might be able to help me with the problems I'm having.
Hi Norma, I'm Carol, the nurse who works with Dr. Smith and the rest of the team. Thanks for coming in to meet with me today. Kate, our social worker who you met when you were at clinic, thought it might be a good idea for us to have a bit of a chat about some of the problems you can experience after the type of surgery that you've had. She tells me that you're a very active 78-year-old lady who had surgery for vulval cancer about 3 months ago, but yet you're having some problems with your recovery after the operation. It's not uncommon for people to experience a number of issues following this sort of surgery. How do you feel your recovery is going?
Well, I must admit, I thought it'd be a lot better by now. I don't feel quite right on my feet, and I'm having terrible trouble passing water. So much so, it's such an issue that I don't like being too far away from my own toilet. So with that, and the walking, I don't get out of the house much at all.
Can you tell me a little bit more about not feeling quite right on your feet?
Well, both my legs, right down to the feet, feel very heavy and tight, and I notice they're swollen. I can't fit into my shoes anymore, and I find it hard to get into the bath. I have to kind of lift my leg over. And I know it might sound silly after all that the doctors have done, but my legs don't look like mine anymore. I may be 78, but with the bowling and the walking, I've always had a good pair of legs. It might sound vain and trivial, but Bill's always admired them, especially when we've taken to the floor at the club. Now I keep them covered. It's making me reluctant to get undressed and have a cuddle with Bill. Not that it's easy to have a cuddle with the legs the way they are, it's too uncomfortable to get into a position.
Any way that the cancer and the treatment affects you is a significant concern, and it's something that we need to address. It's really helpful that you're able to describe it so clearly to me. If you're happy for me to do that, I think I'd like to refer you to the occupational therapist, and what she'll do is do some massage and give you some special stockings which will help reduce the swelling that you're describing. You mentioned that you were having some problems passing urine too.
It's embarrassing whenever I go to the toilet. The urine seems to go everywhere, all over my clothes, all over the floor. It's the reason why I don't like to be too far away from my own toilet.
Again, this is a fairly common problem after the sort of surgery you've had. What happens is when the doctors are removing the vulval cancer, they often have to remove a little bit of the urethra. That's the tube that goes from your bladder to the vulva. And then what tends to happen is when you pass urine, it sprays everywhere. I know it sounds a little bit strange, but we often recommend to women that they buy one of those plastic funnels that you use in the kitchen. What you can then do is put it up against the vulva when you're passing urine, and it will just flow down through the funnel and into the toilet so it doesn't make a mess either in the bathroom or on your clothes. They're also very small. You can rinse them out after you've used them and just carry it around in your handbag so you're not worried about using the bathroom in other places.
Norma's story. Not terribly convenient carrying a funnel around. So let's just go through this. She's clearly getting lymphedema.
That's correct.
Common after vulval surgery?
Very common, probably about 30 to 40% will have some form of lymphedema after the lymph nodes are removed from the groins. It's much higher than for cervix cancer where the pelvic nodes are removed.
Do we know what works?
No, in a word.
But massage probably makes a little bit of difference. I can't imagine there's too many lymphedema masseurs in Tramworth.
Unfortunately, rural areas are really sparse with lymphedema experts or lymphedema therapists.
Patsy?
Yeah, no, it's a really debilitating problem. I mean, I think what Norma described there, that whole notion of it restricts your mobility, she doesn't feel good about how she looks, it can be quite debilitating. And yeah, I mean, I think the best that we have is the massage and the compression stockings, but that really does require really people who are trained in those particular massage techniques. And you're right, they're not actually they're very rare.
And some thoughtfulness and care from Bill.
Yeah, yeah.
What about the urine problem? It's not straightforward, is it, Mara?
No, it never is. One of the problems is that the vulval cancer involves the labia, and the labia act as a funnel to direct the urine flow in a straight line. And so if you remove the funnel effect, then she has to buy another funnel.
Right. Are there any other interventions that weren't mentioned there that would help here? I mean, she's looking pretty depressed.
Well, we're mostly talking about her urine function and her lymphedema. We really are pushing it to be able to do anything. Massage can help, but it won't make it go away. It just controls it, and that really is the effect. And it requires intensive massage, which again is going to be, for a woman in the country, quite difficult.
We've got a question here from Queensland, which is, what if you see the patient isolating the partner due to these psychological issues? In fact, that's what you see Norma doing, in fact. What would you do about that as a GP?
Well, I think in Norma's case, as you said, she does look quite depressed, and she's obviously going through some adjustment phase following the diagnosis, following the treatment, the new body image she's got to deal with. So helping her through that, possibly assessing her from a psychosocial point of view to see if she's actually depressed, if she's got a mood disorder, maybe treating that or getting her some psychological counselling could be of assistance. And certainly I think once you start talking to her about it and saying to her, well, how would your partner feel about the fact that you're maybe rejecting him, maybe something could be worked out there. It's just that's a negotiation that needs to take place.
Kendra, you've seen a wide spectrum of psychological reactions and responses and how it could be managed. Do you want to tell us some stories from your experience?
Well, I think there's just a whole new adjustment after you've had a diagnosis of gynaecological cancer. There's the body image thing is a huge issue, and also wondering about the reaction of your partner. I think women can get quite depressed, so I think that has to be taken into account, and perhaps treatment for some women is really important. In terms of isolation of the partner, ideally it would be good to get the two people together, but that's not always possible. I understand that. There's also assumptions to be made that that partner's the only partner. I mean, I have, in my experience, seen a woman with cancer, not gynaecological cancer, who actually said the problem was not with her husband but with her partner, who was a female partner. Well, I mean, that just, you know, that's another example of not assuming that somebody only has one partner or that their husband is their sexual partner. So it's really about exploring what, you know, from the woman's perspective, what is the problem.
People have other lives.
They do.
There is a way, you have an approach, Patsy, to suggest to people for assessing the psychosexual situation that a woman finds herself in.
Yeah, I mean, I think there are some frameworks which have been developed to really guide us in this area, to really sort of give us some basic tips and principles, and and the model which I'm thinking of that's most well known is called the explicit model, and really what it sort of suggests is the asking permission and asking to actually raise these issues with the woman and her partner if that's appropriate. Is really the start. So the sort of things which people have been mentioning, sort of normalising it and saying, so is it okay do you want to talk about these issues? Then the next sort of step is sort of once you've sort of got that permission, it's giving sort of that limited information about what the sort of issues might be that they may experience. So again, to sort of help people be aware that what may be experienced is common, and that we can, and where as health professionals we can deal with those things. Then you might sort of want to go to giving more specific suggestions around how you deal with those. And again, the sort of practical tips which we've just seen on that video might be how you might approach some of those things. And then, of course, there's always going to be the cases which really where the problems are really complex, and which after we've sort of given those specific suggestions we're really still not getting anywhere, and that may be where you need more intensive therapy, and that may be where you do need to think about referring. So it's just a simple model which sort of, you know, reminds us to ask permission, give that limited information and specific suggestions, but refer if it's out of help that we can give.
Any comments, Norma?
Yes, I think access is the big problem at the end with the referral process for rural women. The fact that this might require repeated counselling sessions with somebody who's specialised in the field, that makes it more difficult. I don't know if it's something that can, from face-to-face counselling, can turn into phone counselling with people who are dedicated for that. That would be good, but yeah.
Maybe there's a place for telemedicine.
Yes.
Yes.
Yeah.
Let's go to our last case study, who's Anna. She's 48 years old. She was born in a country where they don't speak English. She's lived in Australia for 25 years. She came here as a young married woman, lives with her husband and 2 kids who are now in their 20s. Anna had to have a radical hysterectomy and pelvic lymph node dissection for stage 1A2 squamous cell carcinoma of the cervix. She required no adjuvant treatment, and she's waiting to go home from hospital and is seen post-operatively by the clinical psychologist for routine psychosexual screening as part of comprehensive cancer care.
Hello Anna, my name is Rebecca and I'm a psychologist who works with your doctors. I know you've had an operation for cervical cancer, and I usually see all of the women after surgery to talk to them about how the diagnosis of cancer has affected them. How are you feeling?
Well, of course it was a big shock. And I didn't feel sick. It was just the nuisance of the bleeding, you know. When the doctor told me I had cervical cancer, I couldn't believe it. I thought this was a cancer that only women got who had sex with lots of men, you know, like prostitutes. I was so embarrassed. I thought, what does the doctor think of me? I'm not sexually active. I have sex only with my husband, Frank, and we've been married 25 years.
By sexually active, we don't mean that you have sex with other men. It just means that you've had sex at some time in your life.
Well, this virus, this HPV, does it mean that my husband is having an affair and that he caught it and he gave it to me?
Anna, HPV is a very common infection in the general community. The majority of people have been exposed to it. Anna, would it be okay if we talked a little bit about how the cancer might have affected the way you feel about your sexuality? Because it's so linked with sexual function, I find that a lot of women have difficulties in this area after they recover from the operation.
Well, there's not much to talk about, really. I mean, sex is not that important to me. I just do it to keep my husband happy.
Are you telling me that you never have any enjoyment from sex?
Well, sometimes. I suppose it's okay. But I just wouldn't care if I never had the sex again.
How long have you been feeling like that? Is it something that's happened after you found out about the cancer? Or has it been a problem for longer than that?
Well, it's not really a problem, you know. In my country, it's not considered nice for women to talk about sex or to want sex. That's for the men. It's not like these young Australian girls I see on the TV.
Well, is there ever a time when you've suggested to your husband that you have sex? When you've enjoyed it or when you've had an orgasm?
I don't know what you're talking about. My husband decides when we have a sex.
It's really common for men and women to feel differently about the role sex plays in their relationship. Even for couples where the woman does enjoy sex, we know that this can change after they've had an experience with cancer. What we know is that sexuality is an important part of any healthy, loving relationship. I can give you some information to take with you when you leave, and you can take it home and read about it with your husband. I'll see if we've got any in your language. What do you think about that?
Well, I suppose Frank would be happy if we had more sex. I suppose it would be better for me if I enjoyed it too. I'd take the books.
Anna's story. Sounds to me, Mark, that she was pushing uphill there. She could probably backed out a bit earlier. I don't think we've got a willing customer here.
I don't think so. Yeah.
But Patsy, it does raise issues that you could, as a clinician, push it too far, you know.
Absolutely, absolutely. And, you know, and I think what was really nice about that psychologist's approach was that she was trying to understand what was normal and usual for Anna. And I think that, you know, when you're sort of asking them more, after you have those opening questions to try and understand what the concerns are, that whole notion of sort of really trying to understand, well, is that normal and what does it mean to them is really important place to go.
But it comes back to that Aboriginal question, which is who's the right person to talk to this woman? Yeah. Is it a 25-year-old social worker or
who
somebody?
might have a good sex life.
Or somebody else. And the language that you use. I mean, orgasm wasn't part. I mean, she might have kind of known from a book what it was, but it wasn't part of her vocabulary. Introducing stuff that aren't there. Just a cautionary tale. Just finally, if women, Kendra, want to self-manage here more, look after themselves more, don't want to go, is there other places that they can go? You've talked about the helpline.
Yes, the helpline is very good, 13 11 20. Also, cancer councils across Australia have got very good publications, got a whole raft of information for women with gynaecological
You've got some there,
cancer.
Haven't you?
Yes, this is Sexuality, Intimacy and Cancer, which is a Cancer Council New South Wales booklet, and if women want information, they can just go on the website, ring the helpline. The booklets are delivered free. They can be posted out to them, or they can download them from our website. There's also Cancer Council Victoria, of course, have a very good book on sexuality and cancer. And there's a very good CD set, Cancer Council Western Australia have produced 3 CDs about cancer and sexuality, and patients are talking about their sexuality issues, and health professionals, oncologists, nurses, social workers, psychologists, and it's a very good product.
And of course there are the modules from the National Centre for Gynaecological Cancers, and I'll give you the URL for that in a moment. And if we've inspired all these rural clinicians to go and get some training, Patsy, where can they get some training for this?
Yep. Well, these modules which have been developed are designed to be able to be used self-directedly. You can do it at the time and the when you've got time to work through them. So that's one source of training. We're also hoping with this to...
I presume you can go to the Cancer...
sorry,
there's a long URL, but you go to the Cancer Australia website and then you follow the...
There's a cancer website called cancerlearning.gov.au that houses a range of information that Cancer Australia has published, and one of the modules on that is this psychosexual education resource. So yes, I encourage people to work through it, and it's sort of in the process of getting points and those sorts of things so that people can actually use it for CPD.
So what are your take-home messages, Patsy?
Take-home message from me, I think, is really to be comfortable to ask. Ask that, get that right moment around permission, but be comfortable to ask, because I think one of the things that we've all come to realise in this area is that unless we ask, we may miss some really important issues.
Kendra?
My take-home message is never to assume anything about anybody's sexuality, and also when you're under stress and embarrassed, don't resort to medical jargon.
Dysfunction is an easy label which covers a multitude of problems. No woman is perpetually turned on, but that doesn't mean she's dysfunctional.
Carmen?
I think just the GP has the role of being the open door on an ongoing basis for that patient to raise issues and to help them with the problems as they arise.
And I suppose the other message for GPs is know yourself, and if you're uncomfortable with this, know who you'd actually go to and not block.
Who could you use in your local area?
Thank you all very much indeed. I've learned a lot, and I hope you've learned a lot from this programme on psychosexual care of women with gynaecological cancers. Our thanks to the National Centre for Gynaecological Cancers and the Australian Government for funding the programme, but thanks also for you taking the time to attend. If you're interested in obtaining more information on the resources for assisting women with gynaecological cancers, there are some useful internet links linked on the Rural Health Education Foundation's website, rhef.com.au. And don't forget also that there's the Cancer Australia website where you can get access to a lot of this material as well. Don't forget to complete and send in your evaluation forms to register for CBD points. I'm Norman Swan, and I'll see you next time.